As we get going here, I want to thank Bill for the introduction, and indeed, I'm at Children's. I've had the privilege of being at Children's the last 5 years. My experience really goes back some 30 years as a practicing child neurologist. I finished my training at Columbia, and I was in the New York area for many, many years, and I have had the opportunity over these years to care for youngsters with the whole gradient of head injuries from mild to fatal. And so I've developed a keen interest in this, and I recognize that as a clinician that from my perspective I'm attempting to do the best I can, but I recognize that there are a lot of limitations in our treatment, and I think we've kind of hit a wall to some degree, as you can probably make out. So in many respects I've always had a keen interest in the neuroscience and cell biology behind this whole condition. And so I'm actually going to spend my time really talking a little about things which have excited me, which have really developed in the very recent literature, and which I think may have important implications for not just future research, but maybe, just maybe, treatment, proactive treatment. I mean treatment that might actually help before the problems ensue, which is a whole different ballpark, which we love to obviously fantasize about. But in any case, as a child neurologist, these are some of the dilemmas because we have a common cluster of symptoms, as you well know, and they can be very well outlined, as was discussed today, by the neuropsychological testing, the symptom complex. But we basically are in situations we don't have much in the way of identifiable pathology, although Dr. Grant, who's going to be speaking, is going to talk about latest advances in that regard, so they're coming along too. But we often see the sort of outliers, the ones who are referred to us are the youngsters who are having persistent headaches weeks and weeks and weeks and weeks afterwards, youngsters with school failure, the youngsters with mood problems, youngsters who have just become dysfunctional. And there can be many reasons. Many of these youngsters have underlying disorders. That's been a theme today, which has been emphasized. But there are situations, just life circumstances, and sometimes I call it the camel's back syndrome, where the concussion just is a cascade for that individual, and they have become dysfunctional. And it may not be because they're doing so poorly on their neurocognitive testing, but their symptom complex is just infinite. So anyway. And we do treat these youngsters, and Dr. Hawash is going to speak a little about some of the thoughts here in our attempts to determine efficacy. But I also really want to focus on some real issues. How do we determine that a promising high school football player or ice hockey player who's going to get a scholarship to Division I school has already had 2 concussions? Could that person, who's going to have a lot of non-concussive trauma, be at risk for CTE? These are things which obviously we'd love to know about and have some way of anticipating. So. Anyway, the neuropathogenesis of this condition is what I'm really interested in. And there was some very interesting work that has been recently published in the last year by a bioengineer whose name is Kevin Kit Parker. He's at Harvard. He actually is a veteran of the Afghanistan-Iraqi War, and he was involved in cardiac research, cardiac cells, how they integrate one another. But he is now focused on head trauma and blast injuries. And interestingly, in his work, he is looking at aspects of cell biology and molecular cascades. Now, people who follow medicine and neurology and cell biology know that in the last many years, last decade, there's been increasing emphasis on there's an injury, let's say, but then it's compounded by the body's response or maladaptive response to that injury. And there may be intrinsic aspects to that which cause further distress for the body. I think of meningitis, and I think of the inflammation that's developed in the base of the brain. And that child, the bacteria are long gone, but the inflammation, the body's defenses will cause deafness, as an example. So this is where the body's own response can be deleterious. Anyway, his focus is on a part of the cell biology called integrins. And keep a watch on this, because actually, if you look it up in Google, there's a zillion articles on integrins, because they're in most cells of the body. One of the primary examples are platelets, for example. And when the platelet integrins, these cell surface membranes, sense collagen, they begin to form very rapidly an aggregatory clot. So that really forms the first part of clotting. They're very rapidly adapting ways in which the cell can adapt to its immediate microenvironment. And indeed, with regard to head injuries, it does appear that these these cells, whether it be neurons or also vascular muscle cells, which involve blood vessels, can be, and this is the work of Kevin Kidd Parker and his staff, traumatically stimulated. They prop a maladaptive cellular cascade, not necessarily the kind of thing that Bill was talking about, where there's a membrane disruption of the cell or the axon, but this is an internal process where it is basically the outside trauma saying, listen, cell, shut down, retreat, retract. And it's basically responding to that traumatic mechanical stimulation, not necessarily, say, breaking up the pores, but it basically results in a maladaptive response where the cytoskeleton of the cell, microtubules, very important in terms of axons and nerve cells, begin to disintegrate. And in addition, those same cells which are nearby, closely packed, the vascular cells also now go into a situation where they go into a period of vasospasm, something we don't want to see when the body's trying to heal. So it's like this bad process has been initiated. The trauma's long since gone, but the process has been set up. That's an integrin model, anyway, cartoon. And basically, this is the outside part of the cell where the bulk of the molecule lies. This is the cell membrane. This is where the nerve cell or muscle cell or platelet cell, whatever it may be. But they're sort of like Velcro. I kind of think of them as sort of the Velcro of the cells attaching to the extracellular matrix. But they're not just Velcro. They are sensitive two-way antennae. They know what's going on, or they try to determine what's going on outside the cell, and also they can be affected from things inside the cell to reconform outside. So they're very dynamic. They're dynamic Velcro of the cells. When we think of nerve cells, we think of a singular cartoon like this. But remember, this is really, you got to think of the brain as densely packed. It's in a three-dimensional situation. There are blood vessels, there are astrocytes, there are oligocells. It's really, there's all sorts of other parenchymal involvement. And so it is important to know that all these cells are, again, anchored by these integrins. And particularly vulnerable are the areas around the axon and the synaptic area and the dendrites. That's where this sort of stickiness is probably most vulnerable to injury. And so it's less, they're more vulnerable than the nerve cell body, the soma, if you will. By the way, the microtubules, which we'll be talking about in a second, are really within the axon. They're very important with regard to axon transport. And remember, this is a cartoon. The reality is the axon is so much longer than the nerve cell body or the soma. That's really where the nerve cell does its work, and it's long axon. So that's important to bear in mind. Well, I'll get to this again, but this is actually from the Alzheimer's disease education, but we're going to get there. In effect, what Kevin Kidd Parker's work has really begun to demonstrate is that, yeah, there's a message sent out, a chemical cascade in the microtubule of the axon, and it's saying disintegrate, reassemble, and this otherwise flexible, and this is now, just to give you this bluish area, which you can see up top here, is tau protein, something we heard a lot about today already. It actually promotes a certain flexibility about the microtubule. If you lose tau, that microtubule becomes much stiff and less dynamic. But what may happen during that cascade of signals is that it disintegrates, and you have the free tau, which may be released from the microtubule. And that's not such a good thing, as you can imagine, because that may very well end up in the extracellular space and even in transsynaptic transmission, which has been recently demonstrated, which can actually infect other cells. Tau is a very interesting protein. There's a whole model of proteins which exist, modeled on what are called prions, which actually can corrupt other similar proteins and actually, just like an infectious agent, cause them to become dysfunctional and clump, and you get eventually neurofibrillary tangles. So, all right, so this is Dr. Parker's work, and what he basically does, he tends to simulate the mechanical perturbation of a blast wave, and using just rat cortical cells on basically a petri dish, but it's on a flexible elastomer substrate, so we can stretch it and make it go back. And I'll show you a demonstration what it looks like. And he uses also a high tweezer system, a very microscopic one where he can just pull a nerve and then let it go like a rubber band. So he's trying to simulate the concussion, all the multiple forces of concussion. And indeed, it was revealed in his work that you can actually see, depending on the amount of strain, the degree of axonal focal swelling and neurite retraction. And indeed, it does appear perhaps that this cascade could be inhibited by certain medication. And that's the exciting part that might lead to, if you can break this cascade of molecular cascade, which is sort of telling the nerve cell to disintegrate, or the axon, the microtubule, maybe you could actually do something to alleviate the further consequences. So this is what it looks like just in the picture. You can't really appreciate that so well, but let me see if I can demonstrate this. This is a, oops, hold on a second. You can see that. It looks a bit like a concussion. I mean, the way I envision it, basically, and that was the rat neurons in that dish, and they're being jostled at different, and you can do it obviously in different degrees of strain, whether it be 5 or 10%. If you do it violently enough, you will actually disrupt the membranes. But this is at a strain rate which does not disrupt the membranes, but it still causes the problem. This actually is interesting, and I'll have to kind of explain it. This is with a micro teaser, and there's a little bead, a magnetic bead. And what you're going to see if I put it on is this bead is going to be pulled, if you will. And what you're going to look down here where the arrow is, this is the axon. And if you look carefully, it looks like it's pretty continuous, but you're going to see just a few minutes after this, the axon's going to change configuration. It's going to bead and retract. And again, this is without a membrane perforation. Oh my goodness, sorry. I don't know if you could see that or not. Did you? Okay. So I'll do it one more time, because if you're not looking for it, it's hard to see. And I would only comment that this injury is being actually induced on the far side of the soma, but you're seeing the retraction on the upper side. So it's a global effect. It isn't just local, it's global. This is happening through a biochemical cascade. Now, in addition to the nerve cell, Dr. Parker has also done work on vascular smooth muscle cells, taking muscle cells from inside arteries. And he has a very similar attempt to determine the effect on these cells. And indeed, what he has identified is that the push and pull of the acceleration does seem to, in fact, trigger these integrins of the vascular smooth muscle cell, and indeed they cause secondary degree of vasospasm. So I think that's a very important thing. I mean, again, there's the body's maladapting already because it's not supplying adequate blood flow to the injured area. So that's a problem. Now, this cascade, this ROA rock cascade, this is the molecules that propagate this, does appear, just as in the nerve cell model or the axon model, to actually be able to relieve some of the effects. And it's interesting, one of the we know that when you have something called subretinoid hemorrhage, there's typically a vasospasm, and that's well known. The blood products can do that. But this is a situation where vasospasm can occur without necessarily any blood products, just from the perturbation. Okay. I've kind of mentioned this, but I will say that in his work, he's been using this experimental drug called HA-1077, a ROCK inhibitor, and it's also known to be neuroprotective. And again, it offered neuron injury protection, but only when it was applied immediately after the injury. In my fantasies, I think, well, maybe if someone had a concussion and we knew this was going to happen, and they could immediately take some medication for 5 days, and they may alleviate themselves from some of the problems that we see. And indeed, this was this post-injury cascade, and what you're looking at is, in effect, this is different degrees of strain, and this is the untreated degree of focal swelling of the neurites and the axon, and with the ROCK inhibitor, it was significantly diminished. So we go back to this slide again because I think this is going to be an important thing in understanding the pathogenesis, neuropathogenesis of CTE. I think it's very connected. I think tau is obviously a major player, and I don't mean to simplify. I'm hitting the high points. There's a lot of other molecular processes which are involved in this. But nevertheless, there are ROCK-RO inhibitors that are potentially out there already to some degree. They've not been really studied in the way we're talking about, but interesting, statins come about because they may have this effect to inhibit RO kinase. And that may be part of the reason that statins work, by the way, not just by lowering cholesterol and heart disease, but because they have this protective effect on some of those vascular smooth muscle cells. Then there's something called Fasudil. That's not approved in this country. It's used in Japan. It's a calcium channel blocker, and it's used in Japan for subarachnoid hemorrhage. But it does seem to be potentially helpful in other conditions when there's stress, such as acute ischemic stroke. And this is another medicine, which is Patholone D. This is something which actually does help to polymerize the microtubule and keeps it more flexible, if you will. So this may be another agent. And again, you can even use the Fasudil for vasospasm. And then finally, there's an old agent which we've been using, and perhaps we'll talk about, is propranolol. Propranolol doesn't necessarily have effects on the integrin, but it may have an important protective effect on the vasospasm that typically occurs, and we probably don't use that enough from an early standpoint. But there's some pretty good literature in severe head trauma that it may be actually, in terms of mortality figures, it may be helpful. So we probably underutilize it. And those are the two references. Now, I have to apologize. These references are not on the drive that you got, unfortunately, nor not all the complete slides. But if you were to simply go to your computer and Google and write Kevin Kit Parker and write integrins, you'll get these. So, okay. So,
come pull your slides up. So we got about 35 minutes left, so I think that I'm going to skip my part, and I'm going to go to the other two physicians, and then if everybody takes 15 minutes, that'll leave 5 minutes. I'll do the question and answer part. So Karameh Hawash is going to talk about the medical management of concussions. I will simply say most concussions resolve. In high school athletes, 97 to 98% be totally recovered within a month. And so we don't usually use medication to manage straightforward sport-related concussions. If their recovery is prolonged, that's when we do some of those things. And since I think most people here probably know about the initial steps and what to do for straightforward ones, I'm going to skip my part and do the question and answers. Dr. Hawash is a physician in neurology here. She works directly with the Brain Injury Center and the Sports Concussion Clinic, and she's going to talk about the medical management of prolonged cases.
So we heard before about the groups of symptoms that patients with concussion present with. And as most of us probably know, headaches are the most common symptoms. And the headaches can be acute, meaning that they can start immediately after the concussion lasts for a couple of weeks, or they can continue to become a chronic problem and last beyond the 4-week period. The headaches do not always correlate with the severity of the injury. Somebody can have what looks like a very mild injury, but they continue to have severe headaches, and some patients can have a severe headaches with skull fracture, and they immediately recover and they have no headaches after. It's not clear what causes this difference, but hopefully at one point we will start understanding more about what causes this. Headaches do not occur alone. Usually there are other symptoms: sleep disturbances, emotional difficulties, trouble with focus, trouble with concentration, emotionality or irritability. I'll skip the pathophysiology. Dr. Wolff touched on that, and other speakers did. So when we talk about treatment of the headache symptoms or the comorbidity of the headache symptoms, we want a treatment that works quickly, that works very well, that has no side effects, and that seems to be appropriate for the patient that we're treating. Does not always happen that way, but we can always try. The groups of medications that we try are abortive medication, which means a medication that one can use to stop the headache that just started, or preventative medication or for chronic headaches, which is a medication to prevent the headaches from becoming a problem. And these are very different groups of medications. The preventative medications are usually daily medications that the patient has to take every day, and the response of the medication usually is in the 60% to the 70% range. We are trying to understand these medications better and organize our management of patients. So we, at the Brain Injury Center, we try to organize the symptoms into groups, and we try to treat patients according to the most predominant group. So if some patients present with balance difficulties, what we refer to as vestibular symptoms, with these patients we try to understand their symptoms better. Sometimes we refer them to the balance program and treat them accordingly. If the symptoms are mainly cognitive symptoms related to attention or focus, we use stimulants to try to help these patients, or we try to use amantadine sometimes, which seems to work with fogginess or symptoms of decreased focus. If the symptoms are more emotional, we can experiment with using medications like clonidine or guanfacine that have been used for other patients with relatively good results when the main symptoms are irritability. These symptoms are not usually the most predominant symptoms. So I'm going to move to the headaches, which are headaches are the most common symptoms and the symptoms that we treat the most. So when we treat headaches, we try to understand the characteristics of the patient that we're treating and match the medication, match the side effects of the medication to the particular patient. Some patients do present with anxiety, and we know that propranolol is a medicine that helps with anxiety, and it has been proven to work for migraine headaches and for blast injury headaches in the military patient cohorts. So propranolol can be a first medication for a teenager or a patient who presents with headaches and anxiety. If anxiety is not a problem, we also try to treat patients according to age. So below age 10, we hardly ever try anything other than periactin or amitriptyline, because these medications have not been well studied in younger age groups. Going back to this algorithm that we're trying to implement in the Brain Injury Center, we also look at the history of sleepiness. If a patient has a lot of presenting with a lot of sleepiness, we try to avoid medications that make the patient even more sleepy. So we try to avoid amitriptyline, for example, which is known to make you sleepy. And we try to decide whether if the patient has a family history or a personal history of migraine. It is known that Topamax is a very good medication for these patients. So as long as the patient does not present with history of learning disability, since Topamax can cause some cognitive symptoms, Topamax could be an appropriate treatment for that. A patient who does not have learning disability or cognitive issues and does not seem to be excessively, or maybe presenting with some excessive sleepiness, nortriptyline could be a good medication that can be very effective for patients with headaches. Amitriptyline is always a safe choice as long as the patient does not seem to be overly fatigued. Amitriptyline also works well because a lot of patients present with difficulty falling asleep. So you treat them with amitriptyline, they sleep better, their headaches improve. It's a win-win situation. I'm going to touch quickly on other other methods of treatment. I personally like alternative therapy. I always offer it to my patients before pharmacological treatment. it's a good way to avoid side effects. And there are good, robust studies that show that acupuncture works almost as well as pharmacological treatment. Regular exercise works, yoga exercises works, acupuncture works. We have a very good acupuncture clinic that we refer our patients to. Some people have used supplements. Studies with supplements have not been validated very well, but you know, it's something that one can think of with treatment. That's it. Yeah. Thank you very much.
So that was fantastic. That actually caught us up even in time. So that was good. And we're privileged in a way. So, you know, a CT will not show you a concussion, an MRI will not show you a concussion, and for most people, I think that's what they have available. Children's Hospital Boston stole Ellen Grant from the Mass General maybe a year and a half ago or somewhere in there, and she's really on the cutting edge of neuroimaging and ways to detect brain injury that you cannot detect by standard imaging, and she's going to give us a brief overview of the things she's working on. Thanks, Ellen.
So as we get started here, I'm going to just first talk about what we use for initial screening when patients come to the clinic, and then some of the more advanced methods that we're trying to use to detect abnormalities, because like in many other situations, the lines between neurology and psychiatry are blurring, and that is where imaging really plays a role, as we're finding out that more and more of these disorders are actually biological disorders, and hopefully we'll begin to see the concussion with some of these newer methods. So to start here, what is the role of imaging? Basically, we do think about imaging when there's a history or physical exam that's concerning to screen for associated injury. So the first thought is, do we need a CT to rule out intracranial hemorrhages? Do we need to get neurosurgery involved? Is there something acute that we need to manage? If there's nothing acute they're concerned about, then often we'll go to MRI to make sure we can pick up all the subtle abnormalities. So here's an example just of the a normal, actually if there is a point here. I'll try to just use a pointer, of a normal CT scan here, and then we have a CT scan where there's an epidural hematoma, areas of low attenuation indicating that that epidural is actually bleeding at the time of the CT scan. So this is a neurosurgical emergency. Occasionally we'll have kids come in with symptoms of headache or concussion, and we'll have subdurals or epidurals that need acute treatment, but the vast majority are normal. If there's persistent symptoms, MR again is more sensitive for more subtle abnormalities. And here's an example here where using not just the standard T2 weighted images, but more newer susceptibility weighted imaging, we can pick up these punctate foci of hemosiderin in the left frontal lobe that otherwise would be missed with routine screening. These newer sequences, the SWI sequences, are now available in most commercial scanners, and most sites have these scans now. But as has been mentioned before, it's much more common to have normal imaging, and so why do they not feel normal? Routine imaging is really looking mostly at structure, maybe hemorrhage, but there's a lot that we don't see in the routine MRIs that we perform for clinical management. And what we really need to start to look more for are the functional alterations that subserve these concussion symptoms. And advanced imaging may detect subtle functional changes, and I think, as I'll show you, may have determine when subjects should return to play, and may be able to make concussion more of a visible phenomena. Now, if we go back to this graph that you've probably seen a couple times today, I hope, from Giza and Hovda, sort of a classic study in the animal literature about the physiological changes that are expected to occur with concussion, where cerebral blood flow drops and glucose consumption increases. So you have a decoupling of metabolism and flow, resulting in elevated lactate. Now, there are imaging parameters or sequences that we can use to look for these, and I'll talk about them shortly. Cerebral blood flow we can look at with arterial spin labeling, and that gives us perfusion in milliliters per 100 gram per minute. We can look at lactate with MR spectroscopy. Glucose metabolism, we have to go to more of our novel NIRS approaches that I haven't mentioned yet, but there are some sequences that we're collaborating with MIT on that will eventually give us cerebral glucose metabolism on MR as well, too. Also here you see the glutamate peak, and in MRS you can pick up glutamine and glutamate as well. So we know that there are a lot of physiological changes. What we need to do is, from the imaging side, is talk to the physiologists and the people doing the animal work to understand what are the targets we're going through for and start to look for them. So here's a couple examples of MR spectroscopy studies. Most of the studies in the literature have single voxels, such as showing here. And in general, what is seen in the post-concussive subjects are decreases in NAA, decreases in glutamine and glutamate in the early phases, increased choline and inositol that might not appear till later on. There's still not much out in GABA because it's a specialized sequence that we're just starting to play around with, but I think the inhibition is likely to play a role to altered function as well too. Now, in the newer sequences that are coming out, these sequences that running a single voxel like this typically takes about 5 minutes of time. The newer sequences that I'm showing here, you can do a whole volume of brain in about 2.5 minutes, because with multi-channel coils and 3T, imaging acquisitions are really accelerating. So for 2.5 minutes, I can get the same information as a single voxel in the studies above, but in about half the time. So as these sequences become more available, they become more of a routine sequence. We still have to have specific requests for MRS to actually bill for it. There is a post-processing step, but as we show its utility, I think it'll gain more popularity. And as we don't have to worry so much about getting a precise location because you prescribe a slab, these sequences, I think, will become more routine. Perfusion, I think, has a huge potential to really look at physiological changes. We label blood as it's flowing in with a pulse sequence, so there's no injection of any contrast, so you can repeat it multiple times. And we get regional measures at every voxel of milliliters per 100 gram per minute. So it's a true perfusion measure. What I'm showing is an example of a child with a skull fracture on the right compared to a normal child on the left. The standard routine MR imaging was perfectly normal in this child. And we see these perfusion changes. It depends on the age. Typically, the younger kids, often less than about 10 or so, can show a rebound hyperperfusion with injuries, whereas what's been reported in the older age groups over about 11, 12, more typically in the early phases, we'll see decreased blood flow. And if some of these treatments, as was mentioned earlier, are starting to target changes in vascular flow, it would be nice to have a tool that assesses baseline blood flow so we can give treatments and look for response or better determine who needs treatment. Diffusion tractography is another potential tool to look at white matter organization and how that might be disrupted. It is sensitive to axonal swelling, and also if there's enough damage, we can pick up when neurons, axons retract. This is a spinning data set there. That actually was acquired on a routine 3T scanner in 5 minutes. Now I can push it and get even better data in about 20 minutes or 15 minutes, but even routinely we can get images such as the one on the left. And using that, we're starting to see abnormalities in connection to the dorsal prefrontal regions. And there are some reports, again, we're starting to look into that ourselves, of areas where we pick up breaks in the axonal coherence that is likely due to focal lesions that may not be visible in structural imaging. There we go. And there's even more sophisticated ways to start to break this down. When you can take the structural MRIs that are volumetric T1s and parcelate based on the individual's gyral anatomy, look at how many of those diffusion noodles, as I call them, on a tractography data set connect one little region to another region and create these complex correlation maps of a number of connections between each region. So we can take these very complex images and make them truly quantitative and compare in different patient populations. Resting state functional MRI has become also very popular. It's very easy to do. You can combine data across multiple sites and multiple platforms. Basically, all the subject does is sit in the scanner, close their eyes, and you scan. It's an echoplanar sequence that every scanner has. It takes about 6 minutes to get good data. The analysis tools are a little finicky right now, but those I think will be simplified as we move forward. And using that, people are picking up differences in the correlation of blood flow in different regions, suggesting, again, underlying functional differences in how the brain is coordinating. And finally, structural imaging has been shown to have, we've been seeing in other studies that whole brain volumes decrease in kids that have multiple concussions. Focal white matter volume loss has also been reported. There's now tools out there to do more detailed structural images that are pretty automatic right now. So you can get, this is a list of regions that we can assess. So moving forward, we're going to do very detailed regional analysis to see if there's specific regions of the brain that are more vulnerable than others to this multiple concussion type of approach. So in summary, imaging concussion is, shows us that concussion really is a biological disorder. We can pick up changes in metabolites, blood flow, tractography changes in blood flow, in resting state, fMRI, and structural analysis can show long-term changes. I think what we need to do is really, and what we're working on here, is to get programs together to get consistent data, so we get a larger data sets to start to be able to predict going forward what the outcomes are going to be based on, or what treatment should be based on these early biomarkers. Thank you.
That's awesome. So that, I mean, that would make our job easier, right? If we had a way we could see this and see recovery, that would be tremendous. So we actually do have some time. I appreciate everybody's hard work today. I'm going to give you a general approach to concussion management. So you've heard sort of things about complicated stuff and the sort of cutting edge stuff. I'm going to give you the basic nuts and bolts, I guess. Assuming I can find my slides. Why don't I go without them anyway? You'll have to stare at me. That's the only problem. So I'll just tell you about our general approach to concussion management, all right? And there's some experts on concussion management sitting in the audience. David Moore and Janet Kent are in the second row. There's probably lots of people like that out here. So there's different ways of managing it, okay? And I will just tell you what I do and the way we train the clinicians in our clinic. So obviously the first thing is making the diagnosis. I went over a lot of that today in the morning. The history is key. You want to hear the classic history. I was struck, typically in the head. All these things started. Gradually, they're improving. If that's not the history, if the history is that things are getting worse, or there's some focal deficit on your neurological screening exam, you ought to worry about a different type of injury. You ought to think about imaging at that point. Oh, yeah.
Just give me a second.
It's on that flash drive. And you consider imaging to rule out other things. Now, I'm not saying there's going to be something else. A lot of times, kids getting worse and it turns out it is concussion, but you need to rule out something else if that's the story. Now, once you've made the diagnosis, the initial treatment is easy. We've been through this many times today. You simply remove the athlete from risk, take them out of their sport, and you recommend rest. Physical rest, which is intuitive, and all the athletes understand. They avoid working out. And I sometimes find it's helpful to explain to them the whole fact that the brain needs glucose to heal, and if you pull it toward the muscles, you're pulling it away from the healing process. And then cognitive rest, which again does a similar thing. If you need glucose to heal, but then you're spending it on studying for calculus or playing video games, you can't heal. And for the first 2 or 3 weeks, that's all we do. Sorry, I'm just trying to find my slide here. We put them at physical rest, put them at cognitive rest. I don't know where it is. Yeah. And that's all we do. But eventually, some of these kids don't get better, right? So you hit the 3 to 4 week mark, and they're not improved. And there's 3 sort of situations there. Number 1, they're getting worse. I already told you, rule out something else. Number 2, they are substantially better, but they're not 100% recovered, in which case I don't do anything. I say, great, we're on the right course here. We just keep managing them with rest. Then there's the third group, the most complicated group. It's 3 or 4 weeks out. They are not substantially improved. They've been doing true physical rest, true cognitive rest, and you can't just do that forever, right? So what do? Someone was asking me during one of the breaks, how much cognitive rest do you give them? Well, in general, if I'm lucky enough to see them right after injury, I give them 3 to 5 days of full cognitive rest. They stay home from school. They don't even go. If they're better after a couple of days, I say stay home. Even if you have no symptoms, stay home for another day before you try and reintroduce all your cognitive activity. Kids will miss school for, they get the flu. Daddy takes them on a ski trip. I think missing it for traumatic brain injury a couple of days is probably fine, right? But after that period, after 3, 4, maybe 5 days at most home, doing full cognitive rest, I put them back in school, regardless of whether or not they're symptomatic. Everybody can do a class or two, okay? Yes, I realize it might exacerbate your symptoms, but you have to get back in your routine. Actually, Ted Johnson, I thought, did it perfectly. He said, look, you got to wake up. You got to have a purpose. You got to have something to do. That's true. You start to spiral out of control. So they go back to school. Maybe they only do 1 or 2 classes. We give them extra time with tests, extension on their homework assignments, but we put them back. And I don't ask the schools to forgive any work. The child athlete will have to make up that work at some point. And so I think they don't malinger. I really don't think that's what's going on here. I mean, in fact, most of my athletes dread it. They hate falling behind because they know they got gobs of homework to make up. What about the medical management? I'm going to skip all this for time reasons, but people who have prolonged recovery suffer symptoms in categories, clusters, right? They all overlap, just like Karameh said. They all overlap, like Alex Taylor said. But these are the main ones. I find insomnia is intractable for kids who are suffering from chronic concussion. So we treat them with sleep hygiene. We basically explain you need a dark room, you need it quiet, take away your daily planner or the book you use to keep track of your homework assignments, your iPad, your laptop, put it outside the room, because even the presence there, you wake up for a little bit, you'll pull out your phone, text, update your Facebook, right? Put it outside the room, and then I'll often use melatonin as a first-line agent. Most people will be successful with that. I thought Karameh very accurately said, look, you could try amitriptyline. Most kids will have insomnia and post-traumatic headaches, and so a low dose of amitriptyline at bedtime will treat both those things. Treats the insomnia almost immediately. If they've been on it for a while, they will have headaches less often, and they won't hurt as much when they do. And then finally, you can treat poor coordination, balance, vision problems with vestibular therapy. Now, we didn't talk about that today. It's sort of a new emerging field, but I think Dr. Hawash is absolutely right. If their symptoms are mostly vestibular, you can retrain them and alleviate some of their symptoms through therapy, and so we'll refer them to that. And then lastly, I only want to touch on this because everything we spoke about today is not approved by the FDA. And I think the treatments that we've spoken about already are fairly benign, but I think introducing methylphenidate or amantadine is now a step beyond that, okay? And so I just want to say we don't do this for everybody. We don't do this regularly. But if an athlete, particularly a scholar athlete, is now weeks, months, status post their injury, they have objective data showing a drop in their cognitive function, and it is negatively impacting their quality of life, we will try a stimulant. I break it down a little bit differently. There are 2 double-blind randomized controlled trials of methylphenidate in adult patients. And so if they are past puberty, post-pubertal, I will offer them methylphenidate. I do a 6-week course, and then I stop it. And most of them will have improvements of their cognitive function. And even when they come off the medicine, they remain better. So that would be typical for us. If they are prepubertal, I tend to go with amantadine because it's been used in children for years, very low side effect profile, and it's safe. We used to, before there was a flu vaccine, the FDA approval is actually to give to a kid who's totally healthy during flu season so that they don't get the flu. Few things in medicine are so safe we give it to healthy kids, okay? So I think it's a safe thing to do. I give it twice a day, a low dose for a grown sort of full weight child. I'll give about 50 milligrams twice a day. Most of the studies in severe traumatic brain injury used 100 milligrams twice a day, but I give a lower dose for the kids. And again, I do 6 weeks. 2 things to be careful of. I taper them off at the end of the 6 weeks because if you stop it abruptly, there's a risk for malignant hyperthermia. And a fellow in our program a few years ago pointed out to me that in animal studies, it's teratogenic. And so if it is a post-pubertal female and I'm not using methylphenidate, they have to A, be on reliable birth control, and B, we check their HCG. So that's the general approach. The first 3 to 4 weeks, I simply do rest. After that, I consider imaging, I consider vestibular therapy, and I consider medical therapy. And why don't we stop there so we have time? We'll do question and answers for anybody who has things they want to talk about. Yes?
Can you talk about considerations using an agent like amantadine or methylphenidate in a post-concussive patient that maybe having trouble with headache that you think is related to cognitive strain?
Yeah, it's a great question. So the question was, if an athlete or a patient, I guess, after traumatic brain injury has headache, but you think the headache is really due to cognitive exertion. In other words, they say at the end of the school day or in the middle of math class or when I play a lot of video games, something, that's when I get the headaches. To me, that's a cognitive problem. So I would say the answer is to treat the difficulty they're having with cognition as a way of treating the headache. Now, the truth is, treating the headache, much more benign. Medicines we're much more familiar with. And so, you know, if it's early on or they're young, and this is not to say that grades are not important to a 6th or 7th grader, but the long-term effect they're going to have on their life is less than a junior in high school or a college kid. Oftentimes we will simply try to treat the headache first, see if it works. So, you know, all these symptoms clusters overlap, and I think you got to use your best clinical judgment and your comfort level with the medication at that point. Yes. Who's showing a decline. Again, it depends on your setting. So if it's acute, if the injury happened right away, or if they are declining rapidly, I would go with CT because you get your answer in 10 seconds. More often, I think, it's that they have prolonged symptoms. They look well in clinic. They have no focal deficits on your neurological screening exam. And if you're comfortable waiting a day or two or however long it's going to take to get the MRI, I think you get more data. It's more sensitive for brain injury, and there's no radiation. And so in clinic, I generally will go with the MRI. What's that? Oh, without gadolinium. Yeah, unless I'm looking for mass lesion or something, I go without gadolinium. And I think in all the, you know, we've had close to 3,000 athletes in the last few years with concussion. I think I got one CT. It was a hemophiliac. He came in a couple weeks later. Nobody had imaged him, and we just got the CT right away to make sure he wasn't bleeding. But other than that, I think it's exclusively MRI for me. Yes?
I just think one thing with headaches, too, is just connect the rotational trauma is not forget like a cervical headache that holds a lot of critical areas. And if someone has headaches and they're kind of cognitively okay with it, that's not critical headache. Just to make sure that that whole head back articulation is just by the nature of the injury itself.
That's right, yeah. So the suggestion was that since concussion is due to rotational acceleration, you may have a problem at the cervical occipital junction that's causing the headaches, and you should not forget to treat that as opposed to just treating headaches. Yes?
What dose of amitriptyline do you use if you follow EKGs?
Yeah, that's a great question. So the question was, what's the dose of amitriptyline and do you screen with an EKG? I do. I'm a conservative guy. I don't think it's necessary. There's loads of people putting kids on amitriptyline. Especially the doses we tend to use is low dose, 10 milligrams at bedtime. I stole that from my colleagues in neurology. I'd say at children's probably 50-50. Half of them screen with an EKG, half don't. I really think at those low doses, you probably don't need it, but I don't gamble. I don't bet on football, and I get a screening EKG. That's just my nature. Yes.
What we learned about the chronic encephalopathy is that there's more of the tau protein deposited over time. Does that mean the integrin cascade is going to be continuing even though we're now years after the repeated trauma?
It's a great question. Go ahead. Yeah.
I don't necessarily, I don't think there's any real data on this in all honesty, but I think the concern is that since tau may be somehow released, that there's this process of a very slow nature, because this obviously is decades, where like prion disease, which like Jakob Creutzfeldt, things of that nature, this particular protein can, or sort of isoforms of it can deform, and it can corrupt normal protein into almost like an infectious agent to begin the possibility of these tangles, which are one of the hallmarks. So the concern is almost like an autoinfective disease. These things may spread to the extracellular space, through synapses as well. So you've basically established a potential cascade of bad things happening as a result of these kind of injuries.
Yes. Yeah, the question was there's a difference in response to concussion between males and females, and people have suggested that estrogen and even progesterone play a role in that, and he just wanted me to elaborate a little. So there are studies done in animals where you treat the animal after traumatic brain injury with estrogen, and similarly studies done with progesterone in adult patients. With estrogen, it's sort of ironic. So if you take an animal, a mouse or a rat, and you concuss it, and you give it estrogen afterward, male mice or male rats that get concussed and then get estrogen do better on tests of learning, spatial learning, and memory. If you give estrogen to female rats or mice, they do worse. And so maybe a certain amount of estrogen is neuroprotective after trauma, and that female rodents have enough estrogen to protect them, but if you give them too much, it's detrimental. And males don't have enough, and you give them some, and you make them better. With regards to progesterone, so there have been studies in adults where you give them progesterone after TBI, and they have better outcomes, better functional outcomes. And they were preparing to launch a multi-center study in pediatric patients to prove this same effect. And one of my colleagues, Rebecca Mannix, who we work in the same lab over at Mass General, she took immature mice and gave them head trauma, traumatic brain injury, and gave them progesterone and showed that actually they do worse while the adults do better. And this is the second time she's done this. Apolipoprotein E is a genetic allele that most people here are familiar with, E4. And if you're an adult and you sustain traumatic brain injury, that allele is associated with a bad outcome. If you are a juvenile mouse, though, it is protective. And I think most pediatricians know kids are very different than adults. They're not just smaller. They have different physiology and different anatomy. And this is twice now that things we thought were going to be true for kids because they were true for adults were not. And we were on the verge of launching this multi-center trial. Potentially, we would have been detrimental to these pediatric patients. So it's a great question. Very insightful. Thank you.